Hello, everybody. Are we on? It is now 12:15 on Thursday, the 17th. As promised, Sentara Susan here with you for a little lunch and learn. We told everybody 12:15, but I'm going to give everyone a second just to kind of get themselves to their computer, turn everything on, maybe peel back the plastic to that sandwich as you get cozy at your desk. While we get everything up and running. Has everyone been doing well? I don't know if you've looked out your window today. Absolutely gorgeous day, nice and mild in the DMV. A perfect day to learn a little something, take some knowledge with you on your day. I am Sentara Susan Bohoric, and I am I am part of the marketing team and communications advisor for Sentara Northern Virginia Medical Center. We are in Woodbridge, Virginia. For those who don't know, we're just outside of DC, Northern Virginia, right off of 95. And we are a 183-bed, not-for-profit community hospital. We have it all, in addition to some fantastic folks working day in and day out for you. We have just about all the services that you could possibly imagine, including orthopedics, which brings me into today's Lunch and Learn. I am going to have our very own Dr. Angela Tomaschko join us. Hello, Dr. Tomaschko.
Hi.
How are you?
Good. Yourself?
I'm doing great. Wonderful day to learn a lot. And, we're coming out of a long 15 months. A lot of folks probably doing much of the same thing as we're doing, working from home when we can and going in when we can't. And I think that that's also increased folks in their activity. Maybe they're feeling some aches and pains that they hadn't felt before, especially in those knees and those hips. So that's what we're going to be talking about today. Thank you so much for joining us.
Thank you for having me.
For those who don't know, give us a little intro. You're relatively new to the area, and you have a fantastic backstory. You started your field within our armed services.
Yeah, so I did my orthopedic training in the United States Navy. I trained out in San Diego for residency and internship, and then I was stationed here at Fort Meade and Walter Reed as a general orthopedic surgeon for a total of a little over 13 years in the military.
Wow.
Yeah.
That's awesome. Thank you for your service.
Oh, thank you. I also then got out and did a fellowship in hip and knee replacements down in Florida at Holy Cross in Fort Lauderdale. And then I came back up here and joined MedStar, working out of Sentara, and looking forward to kind of building a career here. So it's good to be home in the DMV.
Yeah. Well, you're going to soon find that we have a very active base here in this area because there's so much to do. We've got, beautiful monuments in DC. We have gorgeous walking trails and hiking trails right here in the Commonwealth and everything you could ask for in between. So we have a very active population. And I know a lot of people had seen this promotion on Facebook and said, oh my goodness, tell me more. I'm right there in there. I'm suffering, my knee hurts, my hip hurts. Let's start off with knee replacement. What kind of symptoms are we talking about? You're not just walking into your doctor and saying, hey, I'm here for my knee replacement, because there's a progression.
There is. So, honestly, the biggest symptom of knee arthritis is pain. Pain with activities, pain with walking, pain with hiking, but not all knee pain is knee arthritis. So it's really kind of working with your doctor to get a good diagnosis of what's really causing your pain, and then kind of going through the steps on how to mitigate it. When it is arthritis, it's also looking at how do we control pain but keep activities going, because that's the real balance, is trying to stay as active as possible, live your life, enjoy your life, but also wait to have surgery, until we can't control it anymore. So that's kind of—
what does that look like? Yeah, and as somebody who has had knee surgery, torn meniscus, that sort of thing, it's certainly, down here compared to the total knee replacement. But
it's kind of the last surgery, yeah.
Yeah. When somebody comes to you and they're saying, hey, I'm having this pain, is it PT? Is it cortisone shots? Is it a host of all of it? And who's, I guess, is there a too young or a too old in the way of the perfect patient for any sort of replacement surgery, especially when you're talking knees and hips?
Yeah. So, I mean, it's, starting off with physical therapy, working on all of the muscles, ligaments, to really support the knee, and get it strong, or the hip, but works both ways. Also working with any pains that might not be directly coming from the actual arthritis. So a little bit of tendonitis can happen, things like that. After that, it's steroid injections, gel injections, and sometimes people just need them occasionally and they're doing great still. Sometimes they need them more frequently. When those fail, and the pain that you're having is becoming a disability, it's interfering with your ability to live your life, and that's different for everybody.
Right.
What does that mean? That's when we look at doing knee replacement surgery. So right there is a nice, normal clean knee with no cartilage damage. If you want to go to the next one.
Yes. Oopsie. This is poor operator error here. Sorry about that.
It's all
I was
good.
trying to make the other one go away. But yeah, this I think gives you a pretty good, no wonder we're having pain when you're seeing that bone on bone there.
The cartilage wears away, and we don't have a surgery that replaces cartilage. There are surgeries that do replace cartilage, and they're good for potholes and they're good for, temporary things, but they're really kind of more for our younger patients. But as we get older, and the damage is just more extensive,
Mhm.
that we don't have a surgery that can fix that. Guarantee you we're working on it, but it's just not there yet.
Yes.
And the best surgery is a knee replacement. And that's where we basically cap the end of the femur with a piece of, very strong metal, and put kind of a plate with a keel, which is that piece you go see going down onto the tibia or your shin bone, and then put a piece of plastic in between. So it's actually the metal is on the plastic, and the plastic is secured to the plate on the bottom. And so we don't have the pain with, the actual loss of cartilage with the actual arthritis. The arthritis is gone. Now, all of, for depending on the type of surgery you could have either one or two of your ligaments will be removed, but the implants actually take over for those ligaments. You don't need them. But everything else is still yours. It's your tendons, your ligaments, things like that. Um, there is an age, there's kind of an age target, really. We'd like people to be over 60 years old. The reason for that is that, like everything in life, this is metal and plastic. It's a bearing surface. It wears out. So the average lifespan is around 20 years right now. And so when we've done studies, we've shown that if you're over the age of 60, it's a really good shot of having just one surgery and not having to have a second surgery to replace the knee later on. That being said, we do people who are younger, because it's, when does that pain become a disability?
Right.
You know,
Right. And I
so
think and I think that a lot of people, so we're having some people come in and say, welcome aboard and thank you, and thank you for your service, and a couple of our chats. And one woman had asked, how often with the injections does it, before you get to that point, before I
mhm,
get to my 60 point, my threshold,
yeah.
is it really, I guess it really does kind of depend on the person, how much pain, how active, what they can tolerate, or is there too much?
It's also what works for them. So I always kind of say it's a spaghetti at a wall moment, right? Some people, the steroids really work awesome for them. Other people, the gel injections really work awesome for them. There are other types of injections too. There's one called like PRP, things like that. We don't do them in most of our offices, and insurance doesn't really fully cover them yet. But those can also work for those patients. And so there's a couple of different thoughts of doing injections. One is you do one when you need one. Arthritis has kind of a come and go type pattern. Like you'll have periods of worse symptoms, periods of better symptoms, and kind of so you have this, kind of pattern, and it just kind of goes down over time. Better days aren't as good as they used to be. Worse days are worse, in that process. With that, so some people just get the injections when they're having those really bad periods,
Okay.
or they may get injections before a big event. They're going on a big vacation that they can't have knee pain for. Somebody's getting married, those huge events in life that you just can't miss. You can't
Right,
be.
right.
So some people will get them for those those events. Some people get one, let it wear out, get another. And then when those stop working, when you're not getting what you want out of it, or your injections are just not lasting long enough, that's when we do the knee replacement. And for
So
the
talk
different types of injections. Mhm.
Yeah, I guess that's also just that's why it's so important to have a conversation with your provider so that
Yeah,
you can understand what works for you in your specific case scenario. So
absolutely.
let's talk replacement.
Yeah.
It's funny because we were talking and I was saying that I've had friends, parents who've had knee replacements and who've had hip replacements, and time and again, it sounds like the hip replacement is maybe a little bit easier to take in the recovery, which I initially, I guess, I thought was, I thought, wow, it's a hip, it's huge, and it's, this whole key piece to your body. But I mean, I guess the knee is really doing so much work and taking so much of the brunt of our everyday life.
Mhm. Yeah, hip replacements do usually have a little bit less pain, and it could be the innervation of the area is a little bit less, there's a little more soft tissue covering it. There's a bunch of reasons for that. That being said, both do fabulous. When you look at the numbers, over 80% have excellent results. As in every surgery, there's a small percentage of people that don't do fabulous with it, but the vast majority of people have wonderful results, have less pain than prior to surgery, have more function, and are able to participate, better in their worlds. Whether it be with their kids, their grandkids, doing just living I mean, people who go hiking, play tennis, kind of get back to some of those activities,
Yeah.
you know,
Yeah, you don't wanna be sitting on the sidelines of your life, you wanna be a
absolutely not.
participant.
Yeah.
So, total knee replacement, is this a in-house stay, or am I being released that day? What does my recovery look like? What does the timeline on the surgery itself look like?
Well, it's interesting because this has really changed in the last year. This is something the pandemic did actually give us. Prior to the pandemic, a vast majority of patients who had either a hip or a knee replacement stayed overnight, usually
Mhm.
one night. And when you look like me going back to my training, people stayed 3 to 5 days. So this has
Ooh.
kind of really evolved in the last few years that we found that people do really well. Now, before the pandemic, it was trending towards people going home the same day after hip and knee replacement. With the pandemic, people started really working with that more and more because we didn't want to put people in the hospital where they could have been exposed, to COVID, possibly become infected from an elective surgery, that could have waited. So people started going home the same day. So there's been a lot of great studies in the last year that have shown no difference in between return to emergency room rates, return to complications with going home versus staying overnight a night. And I've found that people really like it. You like being in your own bed. Your cable's going to be better than the hospitals. You have your food. You
Yeah,
know, um, People do better in recovery too because you don't have the call bell and then you're waiting on a nurse. And our nurses are awesome, but they can't be everywhere at every moment. You
sure.
know,
Sure.
um, so you get up and you get your snack and you get your glass of water, and you do those things. You're just being more mobile. You recover a little, probably a little bit better at home.
Okay.
Um,
Okay.
you know,
So
so
a couple hours surgery, then you're released, you go home, and then I have to imagine that there is a boatload of PT.
there is, no matter what we do, whether you're in the hospital or out of the hospital. And that starts right after surgery. And so
Mhm.
to go home, you got to get up and walk.
Mhm.
And people do great. Good pain control right after surgery. They get up, they walk. They may have to do a stair or two to show that they can get in and out of their home safely. And then once
That's fair. Yeah. Yeah. Oops, you've frozen, Dr. Tomasco. All right. Dr. Tomasco, are you with us? Technology. We love it, but we hate it at the same time. Am I right, folks? Dr. Tomasco, I don't know if you can you can hit anything to refresh there, but we are having a little technical difficulty. I think what Dr. Tomaschko was in the midst of saying, though, is that they want you to walk before you leave the hospital and head home, which that makes sense because certainly you have to be able to, once you get out of the wheelchair, get into your car or your vehicle. Perhaps there's a step from the curb to get out of the car. Okay, Dr. Tomaschko, she is going to rejoin us momentarily. One of the things that Dr. Tomaschko had stressed, and I don't know if you guys were hearing that, is that while we are seeing younger folks get knee replacement and hip replacement, ideally here she is, Dr. Tomaschko. I was just telling folks that ideally we want people to be in that 60 age because we want the knee replacement or the hip replacement to last the lifetime and not so you wouldn't have to go under again and get another, so to speak.
Yeah. Well, and we do people, I've seen 18-year-olds get hip replacements or things like that. And that's usually for medical reasons, something happened. And anybody who's young that gets it can get great results. They're just going to need another surgery at some point. So.
Well, you actually are talking hip replacement. Let's talk a little about hip replacement. I'm going to put you on full screen here and bring up a picture of our normal hip. And it's really that what looks like the white piece there, I guess, is the femoral head and going into the socket. And it's so when you see the arthritic hip, that's when you really do see, oh my goodness, no wonder I'm having so much pain.
Yeah, so it's, the white there is the cartilage, and then there's a cartilage, layer in the socket itself. So it's cartilage rubbing on cartilage, which doesn't hurt. But when you look at the arthritic one, you can see how the cartilage wears out. It can wear out on both sides. The pattern is a little bit different, for every person. And then, and that's the bad cartilage rubbing on bad cartilage, bone rubbing on bone that causes the pain. And that's usually felt as either groin pain or buttock pain. So pain will be like in the crease in between, like your thigh and your body, down deep is the most common location where people will feel it. But some people will feel it in their buttocks. It'll kind of be like a deep pain down in there. Not everybody, but.
And then the hip replacement. I mean, this is as we like to say, this is no joke. This is an actual surgery, and there are risks with every procedure. But it's amazing the technology and what is being done because this actually is inserted
inside
into
the femoral
inside the bone. I'm like, oh my goodness.
Yeah, I mean,
wow.
Your femur, your thigh bone has a natural canal. It's, that we actually put it into. We do have to open it up through the top there, and you can see how we kind of take off the old ball and neck that's been damaged over time. And then the part that goes into the bone will actually heal into it. Some people will use cement, especially in older patients. And then, the cement will hold it in the bone. And then the socket you see is actually what we call press fit. So the bone will also heal into that socket. And then just like in the knee, it'll be metal on plastic. So you have that plastic liner that kind of goes in between. Sometimes the head itself will be metal. Sometimes it may be ceramic, depending on, the different, patient factors for what we'll choose there. Yeah.
Okay. Wow, that's amazing. It's amazing to me just to see the science of it and the technology because, I have to imagine, just like I said, within our lifetimes, these things have changed and the technology and the advancements. And I mean, I can't even imagine what this is going to look like. The science of this is going to look like in 10 years. And just the relief that it's really going to provide, our patients and folks who are really suffering in our community.
Yeah. And there's many doctors who do the surgery. And you'll see different approaches to the surgery. Some people go in through the front, some people will go in through the back. Both have excellent results, and it's all kind of dependent on which one works better for the doctor's hands that you're working with.
Right.
So.
Right. Well, I think that we have some questions. Real quickly, is
Yeah.
there anything that you think is important to stress in the way of the procedures or the science or the surgeries with either replacement that maybe I didn't touch on that you wanted to just remind folks of or just even stress?
Yeah, I think the big thing to stress is that it's every patient's pathway is different. And so working with your surgeon to kind of find the right pathway for you, what steps you want to take prior to going down the road to surgery, and then the steps of your care during and after surgery. So
Great, great. Yeah, and I think that's so important to that's why I love the collaborative medical approach because, not only do you have the fantastic surgeon like yourself, then you have the PT folks. And then, it's like every step of the way so that you are hitting your benchmarks and the milestones that you need to so that you can get back to living your life, and I think that's so
absolutely.
important. All
Yep.
right. So we have one woman who writes in. She says, "I'm 62. I had a left knee replacement 5 years ago, but I've had pain in it ever since. Do you do knee revisions?" She's like, "I'm in terrible pain in both knees." And I mean, that's a doozy right there. I've heard of people who
hmm
have had knee replacements on both knees, but traditionally you don't do it at the same time, right? Because I mean, it is such a tough, recovery.
Yeah, traditionally there are a few cases where it will be done at the same time, but no, we don't tend to want to do them at the same time because it's a lot
Right.
for a body to take.
No.
And there's a whole, when you have painful total knees, um, the most important thing is to work with your doctor to try and figure out why.
Yeah.
Because if you don't know why that knee hurts before you do the surgery, the likelihood of that surgery working is very low.
Right. Right.
Because you just know what problem you're going to fix.
True. No, that's a good point. So you do revisions though?
hmm
Okay. But
Yep.
you need to know going in what the main problem is before you do any sort of revision. That makes sense.
Yep.
Okay, I cannot go up and down stairs without support or pain.
hmm
Is that kind of just traditional? I mean, I chalk that up to, oh boy, I'm just getting older. I haven't been working out as much as I should have, or is it maybe your body's, way of telling you, hey, chop, chop, let's go to the doctor. You've got some problems.
It's a little bit of both, right?
Mhm. Yeah.
Certainly some aches and pains are definitely just life. But if it's prohibiting you from using stairs, that's a big deal. And so, trying to figure out why. And stairs are hard, right? It's especially, when you get older. And if you have arthritis, it's putting a lot of pressure through that knee going up and down stairs. So it could be arthritis. It could be another reason as well. So definitely something to take a look at, though.
Right.
Especially since most of our houses have stairs.
Oh my goodness, you're not kidding. Let's see. Next question. How long should recovery take before feeling back to normal?
So there's all different versions of normal.
Hmm.
It usually takes around 6 to 8 weeks before people are feeling like they're kind of getting back into the world.
Okay.
With usually around the 3 to 6 months, they may be getting back to sports.
Oh,
Because
okay.
it's about once you have the strength and everything, then you can start going back to activities. It can take a year before that knee feels like it's your knee or that hip feels like it's your hip again. So there's different levels of normal. Depending on your career pathway, some people will go back to work at 2 weeks, some people will go back to work at 3 months, depending on how much physical labor is involved in your career. Um, but usually around 6 to 8 weeks, people are feeling like they're back in the world.
Will you
So
be using a cane at that point or a crutch, or will you be kind of just walking on your own?
any and all of the above, you
Okay.
know,
Yeah.
you know, um, some people, need a walker for a prolonged period of time. That's okay. Some people, almost practically walk out of the operating room.
Wow.
A lot of that goes into how are you before surgery?
Okay.
If you're a very physically fit person before surgery, it's going to be easier to get off of walking devices, after surgery. If, this pain has kind of been there for a long time and you're deconditioned because you've been avoiding activities for understandable reasons, it's going to take a little bit longer. And that's okay. you
Okay.
know?
And is this a kind of pain that a Tylenol helps? I know that, we hear about the opioid crisis in America. I know a
Mhm.
lot of people are very concerned about being prescribed anything, after a surgery, and they want to be safe and be as safe as they possibly can. But is this
Absolutely.
something, that a Tylenol can help, and maybe you can avoid the opioid, maybe kind of avoid that whole thing, or what do you usually suggest?
That's the hope. So
Mhm.
we usually use a multimodal pain, you know, plan
Okay.
for a patient after surgery. And so there's certain medications that you get before surgery that the anesthesiologist will give you, or you may take a couple of pills right before you go into the operating room, and that's to help control pain after surgery.
Okay.
Most people do require some form of opiates, some level of opiates after surgery, but we try and temper that by using things like anti-inflammatories. So I commonly give my patients, if they can take Celebrex
Okay.
twice a day after surgery to help dull that pain, and then also Tylenol. Ice is a beautiful pain reliever,
Yes, it is.
you know.
We love
So
ice.
ice creams, if they want one, or they can do bagged ice. It's up to their preference. But yeah,
Okay, so there's some options out there.
yeah.
Um, so one lady writes, "Is laser surgery good or bad? I'm almost 76 and I feel like walking on," she says, "I feel like I'm walking on an unstable toothpick." I think she's referring to her legs and her
Uh-huh.
knees, that they hurt so horribly. She says she has had injections, but that really didn't help, but she does have arthritis.
Yeah.
Is there a cutoff also? I know a lot of maybe hospitals don't want to do a surgery after you hit 70 or 75 or 80. Or does it really just depend truly on Susan Bohorik's a great candidate because she does X, Y, and Z, where Susan Bohorik's not a great candidate because she is not doing X, Y, and Z? I mean, is it,
It's about the patient's
okay.
health. Yeah, if they're
Mhm.
healthy enough to undergo the surgery, then we can do the surgery. As far as laser surgery, honestly, I don't know that there's much for arthritis out there. I'm sure some people are trying it, but not in
Right.
our field. So,
Yeah. And this is a true surgery. I mean, this is not a laparoscopic surgery because you have
mhm,
to go in and remove whether it's the joint and put a new joint in. So this is not a little,
mhm,
this is a true surgery. This is truly an invasive surgery.
yes. But that being said, the wound heals great. So you're just going to have a line down the middle of your knee or around your hip. So,
Okay, great. So Arlene writes, "I'm 55 and I've had a meniscus repair, and that did not have a desirable result. And I'm being told the meniscus is gone. I have a lot of pain and stiffness, and I feel like you stated earlier, I'm living life on the sidelines. What would be my options? What are some of her options there? Because it sounds like she's pretty active. She's pretty young, in the grand
mhm,
scheme of things, maybe kind of getting closer, we're all getting closer to, 60.
yeah,
But I mean, she still wants to be living her life and having a life. So what
yeah.
would the suggestion there be?
We usually like start with physical therapy. I'm sure if that particular person has, meniscus repair, that she may have already tried it. But if it's been a long time, a touch is never a bad thing. Sometimes trying different types of injections. Again, that whole spaghetti at a wall method. Sometimes one doesn't work for this patient, but will work for another. There are also braces out there that are called unloader braces that can
Okay.
take the pressure off certain aspects of the knee, and can really get people back to activities. They're big braces, so you got to tolerate that, but some people get great results with them. And then, it's looking at, is there, a surgery like a knee replacement would be beneficial.
Okay. I actually wrote that one down, unloader brace for myself. And then
Yep.
Arlene just was a follow up saying that that was 11 years ago. So yeah,
Yeah.
maybe that's worth maybe revisiting.
Yeah.
Is there a weight restriction when you are having a um, oh guys, I'm getting the notice that my battery is dying. Let me plug in real quick. Is there a weight restriction when you are talking about having a knee or hip replacement? And what do you look for, Dr. Tomaschko?
Yeah. So The reality is obesity causes problems with knee and hip replacements. So we look at what's called BMI, or body mass index. Over 40, unfortunately, complications go up. And so, looking at trying to lose weight, and, we can work with bariatric surgeons, nutritionists, things like that to help get weight down. And it's really up to the surgeon's threshold and when they would want to do surgery. But the cutoff for increasing complications is around a BMI of 40. So that's based on height versus weight. And if you're curious about that, there's tons of calculators on the internet. It's not a great, determination of what's, healthy, but it is what we have. And that's where a lot of the studies were done with. So, but yeah, right around 40 it's not a hard and fast cutoff, but it's definitely, if you're over 40, a more serious conversation has to happen with your surgeon.
Sure. You had
Yeah.
thrown out a great figure when we had spoken previously about the kind of pressure our knees withstand, just in their lifetime. I don't know
Yeah.
if yeah, it was,
Yeah.
and it just was kind of like, whoa, no wonder I have bad knees.
It is around 4 times your body weight every step you take, per joint. And that's, the pressure and the reaction forces and all the physics that go into walking higher, running, or jumping. So when you're looking at, losing weight, a small amount of weight can make a huge difference to your joints. And I have seen people with horrible knee pain, this regardless of the x-rays could have been bad arthritis, mild arthritis, doesn't matter, but have horrible knee pain. And they lost even 20 or 30 pounds and their knee pain almost went away, or did go away in some cases. So weight loss can be a huge improvement in knee pain, and hip pain too. I've seen the same in hip pain as well.
Wonderful,
So.
wonderful. Well, look, I know that you have a scheduled surgery today, so I don't want to monopolize your time here. But I saw a couple little questions, and I think that we had already touched on them. So I just want to, just knock them out real quickly.
Yeah.
One kind viewer says, how long is the hospital stay for a straightforward hip and knee replacement? And actually, as Dr. Tomaschko was saying, that these days they're sending you home.
Yeah.
Depending on patient and what kind of patient you are, maybe what kind of risk factors you might be bringing to the table, and all the above. But for the most part, you get to convalesce at home. So, maybe your mom, maybe your wife, maybe your husband, whomever it might be, they can run and get your snacks for you. That's what I've been doing with my mom.
There you go.
And then one other woman, as we wrap it up, she had just said, if you don't want surgery, is there a cutoff for injections? Is there a say, okay, after 10 injections, no more? Or
No, if they're working for you, if you're getting good results from them, no, you can keep having them. If they're not working for you, then it kind of comes down to risk benefit analysis. And if they're not working, why spend, the time, the money? And it's a small risk, but it's not zero, So, but yeah, not really.
Dr. Tomaschko, thank you so much. What do you want people to know as we wrap it up this afternoon for our lunch and learn about total knee and hip replacement?
It's a great surgery, and it's just, everybody's a little bit different. You got to try a bunch of things first. And, when all is said and done, it works. So, and I hope everybody has a wonderful, summer going on. It's beautiful outside.
Yes, yes. All right. Well, if you want to learn more about the Sentara OrthoJoint Center, you know what? We've got the information for you. You can visit sentara.com/ortho, or you can call 1-855-2-ORTHO-JT. That's also 855-267-8465. Dr. Tomaschko, thank you so much for joining us. This has been a very informative, great conversation. Guys, thank you so much for joining me. I am sorry, I am looking the wrong place. I got a new computer over COVID, and the camera is down instead of up. It's throwing me off. It's crazy over here. Okay, everybody, thank you so much for joining us. Have a great summer. Have a wonderful day. And please, if you need help, don't live in pain. Don't live on the sidelines and let everybody else live your life and have fun out there, because it's just too short. All right, everyone. We will talk to you soon. If you need any help, it is Sentara.com/ortho. Take care.